We're pleased to be presenting at the European Hematology Association the formation of a new collaborative across the UK to analyse real-world data for patients with multiple myeloma. What we know is that real-world data is highly valuable in understanding patient trends, their tolerability to treatment and their outcomes. Also, a major defect with clinical trials is that they typically only recruit patients from certain demographics. We know for sure that patients from ethnic minorities and from poorest social demographic groups are not typically enrolled into clinical trials, and this restricts your interpretability of clinical trial data. And so we've been looking for a means to robustly collect real-world data. One of the problems with real-world data is the poor data integrity, and that's due to the retrospective nature of the data inherently, but also because of manual data collection. The way we're overcoming part of this is by an automated data collection, and the NIHR Informatics Collaborative incorporates 25 to 30 centres across the UK where we harvest routinely collected electronic data across all centres, which is then channelled into a data safe haven which complies with GDPR and regulatory requirements for confidentiality of data, where data merges in an electronic fashion seamlessly and then can be interrogated to answer important questions. What we do is we transform the data into a vocabulary which is known as OMOP. OMOP is a data specification which is patient-centric, not disease-centric. The advantage of this is that you can use OMOP to transform data across any disease group. And so myeloma is one of many disease groups across the whole of health informatics, which means that you can pool resources to make this a very efficient process. We've opened up the pilot, which is running between University College Hospital in London, Oxford and Southampton, and we're planning to ask three important questions of the data set. The first is, what is the impact on ethnicity and social deprivation on outcomes? The second is, what is the impact on genetics upon outcomes? And the third is, when should we treat patients at relapse? Should we treat patients at biochemical reactivation or wait until clinical relapse? And by interrogating a data set which is of over 4,000 patients, we hope to give real-world outcomes to this.